Do you prefer using EOS balloon?
No, no, I don't use balloon since 10 or 15 years. And I think all the world stopped using the balloon, but some centers are still using the balloon. The problem in the balloon is sometimes some air enters inside the balloon, and even a drop of air can mask the field. So we should suck it again and inflate it again. I think the function or the advantage of the balloon is in some patients, the echo endoscope can slip out from the upper second part to the bulb and the stomach. Sometimes the echo endoscope is not stable in this area. So inflating the balloon will anchor or will fix the echo endoscope in this region, so facilitate the examination. But in most cases, or even in all cases, I don't use the balloon. In addition, that it is maybe an expensive, but this is not the principal reason. The principal reason is that no need for the balloon. You can do the whole examination without the need of balloon.
Okay, it's important to differentiate between inferior part if the head from uncinate part.
Yeah, of course. Not so important because the operation will be the same. Uncinate process malignancy is a Whipple operation, and the pancreatic head malignancy is a Whipple operation also. But it is important in small lesions. If there is a small lesion and there is intention for enucleation and not Whipple operation, so they should localize the lesion, whether it is an uncinate process or it is in the pancreatic head. But both are near to each other. And you can see, as I mentioned, you can localize the uncinate process from the station 1 just below the papilla, and you can see it from the stomach in between the superior mesenteric vessels and the aorta from station 4. So it is somewhat, I think it is easy to differentiate whether it is an uncinate process mass and pancreatic head mass. But I think in most of the cases, the operation for uncinate process malignancy and the pancreatic head malignancy is the same, which is Whipple operation. But as I told you, sometimes in difficult cases, and I faced about 4 to 5 difficult cases in the last few months, very small lesions, and they should be exactly located because during exploration, during major surgery like Whipple or distal pancreatectomy, the pancreas is a retroperitoneal structure. You can't see the lesion if it is deep, if it is not on the surface or bulging on the surface. If it is a deep, you can't localize it. And if the lesion is deep, you can't even palpate it. So it is very important to describe the location of the lesion. But this is fewer cases, it's not the case in most cases.
Okay. Is it different to do EOS in gastric bypass patient?
Ah, of course, very important question. Very important question, really.
Good.
Because if there is enterectomy, and the only way, and the only pathway is bypass. You can pass from esophagus to the stomach, and the only pathway is the gastrojejunostomy stoma. Unfortunately, the gastrojejunostomy stoma some of the abdomen. So it is somewhat very difficult to visualize the pancreatic head. You can visualize the pancreatic body and tail very nicely because you can visualize it from station 4 just below the cardia. But the pancreatic head here is very difficult to visualize, even from station 4, because the jejunal lobes are filled with structures. Even if we try to localize the pancreatic head from the stomach, as I mentioned in station 4, you interfere with the jejunal loops, the afferent and efferent loops of the jejunum. So in case can visualize pancreatic probably really. And I faced this problem many years ago, and Sometimes I can't see the pancreatic head. It is shadowed by the jejunal loops. And of course, I can't go to the duodenum because there is anatomy, and the way is obstructed. There's no way to the duodenum. So when there is a case referred by gastrojejunostomy and antrectomy, I told the patient that the chance to frustrate pancreatic head is about 20 to 30% only. But if the mass is in the pancreatic body and tail, and this is usually the case because these patients had Whipple operation. So this is pancreatic duodenectomy. The duodenum was removed, and there is gastrojejunostomy. The recurrence is usually pancreatic adjacent pancreatic body sometimes state. So it is very easy to localize just below the cardia. But if the recurrence in the pancreatic head, the chance to visualize the pancreatic head is only 20 to 30%.
Okay. To diagnose common bile duct stone or other common bile duct pathology, which station is more preferable to look for?
The three stations, all stations. Station 2 at the papilla to visualize the most distal part of the common bile duct as the region of the papilla. It is very near the echoendoscope. It is important. And of course, the upper second part, as I mentioned, and the bulb of the duodenum. So you can use all stations. You should use all stations. I told you that you can see all the stations from, you can see all the structures from station 4, but this do not mean that you don't need to examine station 1 or 2, 3. Of course, you should examine the whole stations. You should use all weapons. You should use all stations and marks. You can examine the gallbladder from different views. You should examine for the station 2 at the papilla. You should examine from the upper second part. You should examine from the bulb of the duodenum, and you should examine from like that station 4. You can examine it from the station 4 if there is gastric outlet obstruction, so you have only one station. But in the normal persons with when you can go to the duodenum, then you should examine from the all stations, of course. It goes without thinking. You should examine from the whole stations, and you can see the stone from many stations. If there is common bile duct stone, and I can see it from the region of the papilla if it is in the distal part, and I can see in the duodenal bulb if it is in the distal or middle part, and I can see it from the stomach also in any part of the common bile duct, especially in thin patients, as we saw in the two videos in station 4 with large stones in the distal and middle part of the common bile duct.